Hello, I'm Dr. Jeffrey Hayes, the ASRM Education Specialist, and the following presentation is a review of our Practice Committee opinion on postoperative adhesions in gynecologic surgery. Postoperative adhesions are a natural consequence of surgical tissue trauma and healing. Peritoneal adhesions may result in infertility or pain or bowel obstruction, and may increase the technical difficulty of subsequent abdominal or pelvic surgery. Studies conducted by the Surgical and Clinical Adhesions Research Group, or SCAR, have analyzed the records of surgical patients in Scottish National Health Service hospitals and helped to define the epidemiology and impact of postoperative adhesions. In the Scottish experience, accepting laparoscopic sterilization procedures, open and laparoscopic gynecologic surgery can both be associated with adhesion. Another retrospective study of Canadian women admitted to the hospital with a diagnosis of small bowel obstruction after gynecologic procedures found that hysterectomy was a significant cause of adhesion-related small bowel obstruction and that laparoscopic supracervical hysterectomy was associated with a lower risk compared with abdominal hysterectomy. Postoperative adhesions increase operating times and the risk of bowel injury during subsequent surgery. Adhesions also have major financial implications. In the United States, adhesion-related healthcare costs exceed $1 billion annually. The most important potential consequences of adhesion formation are infertility, bowel obstruction, abdominal pelvic pain, and injury to intra-abdominal structures at subsequent surgery. All surgeons must be familiar with the risks and consequences of postoperative adhesions. Theoretically, formation of adhesions might be reduced by minimizing peritoneal injury during surgery, preventing the introduction of reactive foreign bodies, reducing the local inflammatory response, inhibiting the coagulation cascade, and promoting fibrinolysis, or by placing barriers between damaged tissues. Formation of postoperative adhesions often may be minimized by careful surgical technique with adherence to microsurgical principles, including gentle tissue handling, meticulous hemostasis, excision of necrotic tissue, minimization of ischemia and desiccation, use of fine non-reactive suture materials, prevention of foreign body reaction and infection, and use of minimally invasive surgery. Also, the incidence of postoperative infection is lower after laparoscopy than after laparotomy. And, regardless of the surgical approach selected, procedures such as myomectomy often result in adhesions. Types of adjuncts to surgical technique that have been used to reduce postoperative adhesions include peritoneal installation and surgical adhesion barriers. There are only 3 anti-adhesion barriers approved by the United States Food and Drug Administration. They are all designed to be present in the peritoneal cavity to act as barriers during the critical 3 to 5 days that mesothelial repair occurs with or without adhesion formation. A number of different agents have been used for peritoneal installation in an attempt to decrease adhesion formation. However, their effectiveness remains in question. Peritoneal lavage with an antibiotic solution has not been shown to reduce adhesions, and some antibiotic solutions might promote adhesion formation. Heparin solutions have been used in an effort to decrease adhesion formation. However, a clinical trial of peritoneal irrigation with heparin solution did not appear to reduce peritoneal adhesions after pelvic surgery. Likewise, studies of irrigation with a crystallized solution of 32% dextrin 70 with or without heparin or corticosteroids have not demonstrated reduced adhesion formation. Icodextrin 4% solution has been FDA approved for adhesion reduction in patients undergoing gynecologic laparoscopic adhesiolysis. Although a randomized pilot study observed that use of the solution reduced adhesion formation, a subsequent systematic review concluded that there is insufficient evidence for its use as an adhesion-preventing agent. There are 2 FDA-approved surgical barriers that have been demonstrated to decrease postoperative adhesion formation. A thin bioresorbable membrane made of modified sodium hyaluronic acid, or HA, and carboxymethyl cellulose, or CMC, has been FDA approved for use during open surgery to reduce adhesion formation. Whereas a randomized study of women undergoing open abdominal myomectomy demonstrated that HA film used reduced adhesions formation, A subsequent systematic review concluded that there is limited evidence for its effectiveness for preventing adhesion formation after myomectomy. A large prospective multicenter trial of patients undergoing intestinal resection observed no overall difference in the incidence of postoperative small bowel obstruction. A cloth-like bioabsorbable adhesion barrier made of oxidized regenerated cellulose is FDA approved for use at laparotomy to reduce adhesions. Multiple prospective studies have shown that this product can reduce new and recurrent adhesions by 50% to 60% after both laparoscopic and open abdominal surgical procedures. However, there's no substantial evidence that the use of either of these FDA-approved anti-adhesion barriers improves fertility, decreases pain, or reduces the incidence of postoperative bowel obstruction. In summary, postoperative adhesions are a natural consequence of tissue trauma and healing. Postoperative pelvic adhesions may result in infertility, pain, and bowel obstruction. Adherence to microsurgical principles and minimally invasive techniques may help to reduce postoperative adhesions. To read the committee conclusions and further data on postoperative adhesions in gynecologic surgery, please click on the link to the full text of the opinion on the next slide.